I'm Dr. Sanjeev Chopra, a professor of medicine at Harvard Medical School, and I'm privileged to be the host of Know Your Health. This morning's guest is Dr. Martin Abrahamson. He's a trusted and valued colleague. He and I co direct the Division of Continuing Medical Education at Harvard Medical School, and we travel nationally and internationally to conduct continuing medical education courses. Dr. Abrahamson is an associate professor of medicine at Harvard Medical School. He's a brilliant clinician and scholar and a world renowned diabetologist, specialist in diabetes. So, good morning, Martin. Welcome to the show.
Good morning, Sanjeev. Thank you so much for inviting me to participate in this program. I'm delighted to be part of Know Your Health and honored to spend the next 15 minutes with a dear friend and colleague talking about a topic that's near and dear to me, that's diabetes.
So, Martin, you're a specialist in diabetes. For many, many decades, you've seen thousands of patients, you've been involved in publishing and clinical trials. If I were to ask you, and that's what I'm going to ask you right now, what is one of the most important advances in the treatment of type 2 diabetes that has come around in the last decade or so? And as you answer that, please explain to the audience the difference between type 1 and type 2 diabetes.
Okay, that's a terrific question. It's a difficult question because there have been so many advances. But let me first start off by defining what we mean by type 1 and type 2 diabetes. Type 1 diabetes used to be called insulin-dependent or juvenile diabetes, but we now know that it can affect people at any age, although predominantly affects young adults and teenagers, children as well. It's what we call an autoimmune disease, whereby the body develops antibodies against parts of its own body, in this case, the cells that produce insulin, which come from the islets of Langerhans, which is part of the pancreas. And these antibodies destroy these insulin-producing cells with the result that people with type 1 diabetes need insulin to survive. Now, this is different from type 2 diabetes, which is caused by a combination of factors. The first is a condition which we call insulin resistance, where the body does not respond to insulin as well as it should. Insulin resistance has some genetic contributing factors, but is also very closely associated with another very common condition called obesity. And in addition to this insulin resistance, the pancreas then develops an inability to respond to the increasing demands for insulin secretion and begins to falter. And this combination of insulin resistance and diminishing secretion of insulin from the cells of the pancreas leads to elevations in glucose. We now know there's some other factors that contribute to the elevations in glucose, but these are the two major issues that lead to type 2 diabetes. It used to be called adult onset diabetes because it used to be affecting only older people generally over the age of 45. But unfortunately, with the epidemic of obesity in this country and other parts of the world, we now see type 2 diabetes occurring in younger and younger age groups, including children and adolescents, which is sad to see. Now, let's move on to talk about the advances. In the last decade, I would say one of the major advances that we've seen has been the development of new drugs to treat type 2 diabetes. Before I tell you about the drugs, let me first of all tell the listeners that whatever drugs we use to treat type 2 diabetes, there is something that is fundamentally important in the management of type 2 diabetes, and that is maintaining a regular exercise program. Exercise actually improves what we call insulin resistance. and also following a meal plan that, if necessary, includes a weight loss program. But having said that, the majority of people still require medications. And the advances have been these two classes of drugs that are called, firstly, GLP-1 receptor agonists, or incretins, and I'll tell you a little bit about incretins in a minute. And the other class are called SGLT2 inhibitors. Let's talk about the GLP-1 receptor agonists. These are drugs that were discovered some years ago through very articulate experiments and scientific studies, whereby first it was discovered that when food enters the stomach under normal circumstances, there is a message is sent to some cells in the intestine to produce certain hormones that augment the insulin secretion that is required to maintain glucose in a normal range. So if food goes into the stomach, these cells almost prepare the pancreas and tell them you need to make more insulin because food's coming down the road. We know that this phenomenon is diminished in people with type 2 diabetes as well. But this discovery that was made some years ago was that in the saliva of a particular reptile called the Gila monster, there is a hormone which actually helps the Gila monster digest its food. And that hormone actually works like these hormones that are secreted from the human body to augment insulin secretion. And so these GLP-1 receptor agonists, which we call them, are actually derivatives of this hormone, which augments insulin secretion. These medications, until recently, could only be given by injection. The first of them had to be given twice a day. Then the next derivative was once a day, and now those injections can be given once a week. But in addition to that, there is an oral version of one of these medications that has recently become available. And what these medications do is they help the pancreas produce insulin as it's needed to lower glucose as food enters the stomach, and then the food is broken down into, the carbohydrates are broken down into sugars, and then those are absorbed and cause an increase in the blood glucose levels. So they help make insulin to reduce glucose. They also stop the production of other hormones that may increase glucose levels. They actually make people feel less hungry, and their use is associated with weight loss. More importantly, these medications have now also been shown to reduce the risk for heart attacks and other cardiovascular problems in people who have either had a heart attack before or who are at very high risk for heart attacks. And we now know that people with type 2 diabetes often have other coexisting problems that increase the risk for what we call cardiovascular disease. They often have high blood pressure, they often have high cholesterol, and so this combination of these risk factors increases the risk for cardiovascular disease, and that is actually the commonest cause of death in people with type 2 diabetes. These drugs lower that risk. So in addition to lowering glucose, they also lower the risk for heart attacks and therefore reduce cardiovascular mortality. And they also are associated with weight loss. The other very interesting thing about these medications is that if they are given alone or with another common drug called metformin, they cannot make your glucose go too low in the body, which is very, very important. Now let me turn, because time is, we're pressed for a bit of time. So I'll turn to the second class of drugs, unless you have any questions you want to ask about the first class.
Yeah, I wanted to say wonderful information and so brilliantly articulated. Many times medicines come to the market after there have been many, many clinical trials. Then the Food and Drug Administration approves it. And then post marketing and surveillance sometimes shows unintended benefits, which is such a surprise, but here it is wonderful. So people are losing weight and they're lowering their risk of getting a heart attack. That is just wonderful news. Are there any unintended side effects that we've seen with these medications? What are the major side effects?
So with these medications, the one common side effect is nausea. And that actually gets better with time in the vast majority of people. And we also reduce the risk of nausea by starting the medication at a low dose and then building the dose up slowly. We also know that if people don't eat as much as they normally do, if they don't eat until they feel totally full, eat until they feel half full, so to speak, and avoid fatty foods. In other words, have smaller meals, avoid lots of foods that contain fat. You reduce the risk of developing nausea. Now, there are two what we call contraindications to this drug, which actually haven't proven to be real contraindications, but they are still in the what we call the black box warning of these medications, which the FDA puts out. There is a contraindication if you have had a very rare form of thyroid cancer called medullary cancer or medullary cancer of the thyroid, or if you have a family member with that cancer. Now, that's a very rare form of thyroid cancer. The commonest forms of thyroid cancer are what we call papillary or follicular cancer of the thyroid. These drugs are perfectly safe to use in individuals who have had a history of these cancers. And there was an initial concern that these drugs may be associated with an increased risk of inflammation of the pancreas called pancreatitis. We now know that that's not the case, but if anyone has had a history of pancreatitis for which there's been no known cause, then we shouldn't use these drugs or try to avoid using these drugs.
Terrific. You talked about type 1 and type 2 diabetes. Which one is more common, type 2?
Type 2 occur, 95% of people with diabetes have type 2, 5% about type 1. So type 2 is much more common. And the sad thing about diabetes is that it's increasing in prevalence throughout the world. So the numbers of people with diabetes are staggering, and it's mainly type 2. And the association with obesity and an increasingly sedentary lifestyle is what's driving this increase in diabetes around the world.
Martin, in our profession of medicine, learning is a lifelong privilege. And we learn from continuing medical education courses, we learn from weekly multiple conferences at academic medical centers, community hospitals as well have these conferences. We learn from medical journals. We learn from our colleagues. We learn from our students. We learn from the nurses, the pharmacists, the social worker. But also importantly, we learn from our patients. Our patients can be our teachers. You have written and invited an amazing lady, very inspirational lady from Canada, and she came to our course, Updated Internal Medicine, a few years ago. I think we had 500 people, clinicians from 45 countries, and she got a standing ovation. The two of you were on stage and you did a wonderful chat with her. Can you tell us her story, please?
Sure, I'd be happy to. And then if there's time, I'll come back and tell you about the other class of medications just briefly. So you know that I have articulated, like you have articulated, that in the years of looking after people with diabetes, one of the most inspiring aspects of this profession has been developing relationships with patients who have chronic conditions and learning a lot from them. And this particular lady that you're talking about, I first met when she was already 73 years of age, and she'd had type 1 diabetes since the age of 8. So she already had diabetes for about 65 years. And she had been born in Canada. She had developed diabetes at the age of 8 in 1937. Now, if you think back to 1937, we didn't have blood monitoring. We didn't have a test called hemoglobin A1C, which measures your average glucose control. We didn't know that good glucose control really made a difference to risk for developing complications of diabetes. All this lady had was one form of insulin that was what we call regular insulin, developed from, extracted from pigs, porcine insulin. And the needles were long, wide bore needles. The syringes were not were not disposable syringes. They had to be boiled. And she was homeschooled by her mother, who was very protective and taught her nutrition, taught her how to weigh her food and measure her food, and initially injected her with these huge syringes and with insulin. And she was very protected for many years. Then she left home, eventually went to college. But her mother instilled in her the discipline to manage diabetes, and she was forever grateful for that. She used to monitor how good her control was by boiling her urine with a special reagent called the Benedict's reagent with a Bunsen burner at home. And if it turned a certain color, she knew that she had too much sugar in her blood and therefore her urine. And if it didn't turn a certain color, she was okay. Well, she basically lived through the huge advances that we've witnessed in diabetes management over the years. And she had a number of setbacks. And the one thing that inspired me about her more than anything else was when I first met her, she'd already had some setbacks, but she let nothing let her down. She was resilient. And in the face of what she might have called adversity, she looked for all opportunities for a positive aspect in life. In fact, after more than 50 years of diabetes, I think, she took up curling. She always was an avid exerciser. She took up curling and she represented the United States in a national curling championship. She traveled the world with her husband. Her husband was an aeronautical engineer. She met him when she was at college, I think. Then he moved, that's when she moved to the United States. She traveled the world with her husband. She became pregnant when doctors had told her, you'll never have children. She ultimately had 3 children. She spoke so highly of the doctors who looked after her during her pregnancy and was forever grateful for the doctors who took care of her during those times. She developed a condition called celiac disease, which we know is common in people with type 1 diabetes, much more common than in the normal population. She described how she flummoxed doctors with all her symptoms because at that time, nobody really understood the connection between the two. She lost a lot of weight, but she regained her confidence, and she then went onto a gluten-free diet, which she stayed on for the rest of her life, and it didn't bother her. She said, that's okay, I can manage with this. She had a heart attack. She never let that stop her. She went on and continued curling. And every time I would meet her, she would always ask about what's the newest advances. And she embraced all of the advances in diabetes. So when new insulins became available, she was the first one who wanted to try it. In her 80s, she switched from disposable syringes, to using insulin pen devices. In her very late 80s, when forms of continuous glucose monitors became available, that you could wear a sensor on your arm for up to 2 weeks at a time and use a little reader device to measure your glucose, she said, I'm going to start using that. And this is how she lived until...
I was sorry to interrupt. We have another minute or so. You did a calculation. How many thousands of injections of insulin did she get? So during her life? In
summary, she lived for 82 plus years with diabetes. She died 6 months after her 90th birthday. We calculated that if you'd had type 1 diabetes for 82 years and you took 4 shots of insulin a day, which is standard, and measured your glucose level 4 times a day, and now we know there are devices that you don't need to do that, she'd have taken 120,000 injections roughly.
Amazing.
And pricked her finger at least 120,000 times.
What an inspiration.
So she was truly an inspiration.
We're going to close in the next 30 seconds or so. And sometimes we refer to this segment as Coffee with Dr. Chopra. So I want to ask you a question.
Coffee with Dr.
What is the relationship between coffee consumption and type 2 diabetes?
Well, you and I know that we exchange scientific articles about coffee. We've been doing this for years because we both are fascinated by coffee. But coffee has been shown in many large, what we call epidemiological studies. These are studies of population groups, not controlled studies or anything like that, but studies of just people looking at their behavior, for example, and seeing if they can correlate things with certain disease outcomes. We now know from studies around the world that people who drink coffee have a reduced risk for the development of type 2 diabetes. And it seems to be an independent component. So it's not as if, well, I drink coffee and therefore I'm more likely to exercise, or I'm more likely to control my weight. It seems to be an independent contributing factor.
And it turns out both decaf and regular coffee confer that protection.
That's correct. Correct.
All right. So with that, cheers. And
cheers. The time is up. Unfortunately, we never got to speak about the other class of medication.
Yeah, maybe we'll do it in another segment.
Look forward to it.
Thank you so much for sharing your wisdom and expertise with all of us.
Thank you for having me on this show.
And have a great day.
You too. All the best.